Welcome to From Our Generation, where we uncover the ideas and events that shape the world we live in today. I'm Crom Carmichael.
And I'm Mike Hassel.
Together we'll explore the past to better understand the present, because history isn't just about what happened, it's about how you think about it. Well, Michael, we are here today for a special podcast. We're going to be doing one on healthcare and our healthcare system, the healthcare costs, how we got here, how it impacts various age groups. Primarily, it affects younger people, costs them a lot more money than it should, and how we got here and what it means. And then more importantly, and I think most importantly, is some ideas on how it can be reformed to lower the aggregate or the total cost of healthcare.
Well, it's such an important topic because it's tempting to just say that's beyond my control. You know, I can't change it. I just live with it. And what we want to talk about is some choices that have been made that got us to this point. They could be unmade. That'll be something we can discuss. But our inability to control our healthcare expenses is a huge problem.
Yes. Okay. So let's kind of begin by talking about our healthcare system is a combination. I've got a few notes here. It's a combination of government-funded, government-regulated programs, a combination, and that's you have a private system that is heavily regulated and operated almost exclusively through highly regulated third-party insurers and adjudicators. Now, what I mean by that is this, is that everybody who accesses our healthcare system, even if it's a simple doctor visit, they cannot, except under unusual circumstances, meaning there are people who go to a doctor that's called a concierge doctor.
That they pay directly.
That they pay directly, and they generally, for a concierge doctor, I'm trying to separate this, define it and separate it quickly. A concierge doctor is a doctor who says, I will serve 500 patients a year, and each patient will pay me $2,000 for the whole year, and they'll do it up front. And so the doctor now has a practice with $1 million of revenue and has no third-party payment at all. They've now collected their money, and they provide health care as the primary care physician. Those are unusual. That's not the norm. So we're going to stick with the norm, and then we're going to talk about how it got this way and then what can be done about it. But the norm is that even if you want to go see the doctor, you go in and put down your insurance card, and the person there says, you've got a $35 copay or a $40 copay, and go see the doctor.
So there's this giant system that's going to then take over and decide what gets paid and how and when, et cetera. One way to understand this is to look at the alternatives. England has the national health system. They provide the service. Right. What you're saying is in the United States, the government doesn't own most of the hospitals. It owns some, like the VA, but mostly it doesn't provide the service.
Correct.
If we go back to the island, our original podcasts were this very simple economy where people were just surviving and they were doing the work to support themselves and sometimes selling their services to others. There would be no health care in the most primitive societies, right? And if you did develop health care, you finally got an educated doctor way back when, you would pay him. Maybe not in money, maybe in a bushel of corn or something that you had to pay them. The most simple bartering transaction. So you would buy it, and it was over. You paid him at this point of service, and it's done.
Yes.
We have neither of those.
Correct. And in fact, healthcare is the only thing in our society that you don't pay for it at the time that you use it. Everything else you pay for, except maybe your utility bill. But you then pay for your utility bill. You get a bill and you pay it, and nobody else is paying it for you, and then trying to balance it. But
that's the market system, and the genius of the market system is people buy what they want, and they don't buy what's too expensive.
Right.
The market has been taken out of the way we consume healthcare.
Yes, everybody is mandated to buy some form of healthcare, which is then adjudicated by a third party, meaning that a third party is setting the price, setting the level of service, and then handling how much of that you have to pay and how much an insurance company will pay. And it is that part of the process that has driven our healthcare costs in total to amounts that are not sustainable over time.
But
So
we're talking about a couple $1,000s a person per month, something like that.
where we are now is $5 trillion total, which is $15,000 per person per year.
Per year.
So for a family of four,
yeah,
their burden for our total system is actually $60,000 a year is the burden on them in one form or fashion. A lot of it is they pay huge insurance premiums out of pocket. Maybe their employer pays a huge insurance premium and then has to pay them less money because you can't. The amount of money you can pay is not infinite, and or you're on some kind of a subsidized plan like Medicaid, where the taxpayers are paying the balance.
Well, somebody's got to pay it.
Somebody has to pay it. Yeah. And what I'm trying to get at today is that there are really two parts to our healthcare system that I want to discuss. One is what the providers are providing, because I believe that is generally a good thing.
A good system. They're well educated. They deliver a good service.
Yes, and then there's the payment part of the system, which now represents about 60% of the total costs. Is the payment system.
That's astounding if it's true.
Yeah, and I want to make my case for it being 60%.
Okay.
And so let's look at the total here. It's $5 trillion, $15,000 per person. That $15,000 per person is twice as much as the second highest spending country in the world. So that's 50% of my 60% is just in that number alone.
Okay.
And so what I want to do is I want to talk about how we got to where we are, and then I want to try to describe where we are. Up until Roosevelt in World War II, up until then, the average American, the typical American, the only insurance they bought for health care was for hospitalization. If they went to see the doctor, they paid for the doctor at the time that they visited the doctor.
Yeah, so insurance was for catastrophic events that would strip away your ability to pay.
Right. And by the way, we buy homeowners insurance on that same basis. Our homeowners insurance does not cover the plumber coming to fix the plumbing. Right. Or it doesn't cover, even if you need a new HVAC system, your homeowner's insurance doesn't cover a new HVAC system. It doesn't cover needing an electrician to come and fix something. Yeah. It only, if the house is damaged beyond a particular amount, that's the only time you ever interface with your homeowner's insurance.
So the equivalent in healthcare is routine maintenance, or just when you get a cold and you have a minor illness. The insurance is for a major accident, a major chronic illness, an acute episode like a heart attack or something that's going to overwhelm your ability to pay. But it's not intended. Insurance originally wasn't intended to cover every jot and tittle that happened to you.
Exactly. And so the question is, how did it get that way? And what happened was, at the end of the Second World War, Roosevelt had put wage and price controls into our economy at later stages of the Depression and in particular the Second World War. Businesses came to Roosevelt at the end of the war and at the end of his life and said, "Mr. President, we're making good money. If you want to keep the price controls in, that's okay. But we'd like you to take the wage controls off because we'd like to be able to pay our employees more money." And he said, "No, I will not do that, but I will let you pay for their health insurance, and I'll let you deduct it." And so for the first time in our history, businesses could pay for health care and deduct it, and employees in the past were paying for their health care after they'd paid their taxes. And the average person's taxes at that time was in the 25 to 30% range. And so having your employer pay for your health care was a real benefit. It was like getting a nice increase in your wages. And so that was passed into law. And then the private sector unions saw that, and they then negotiated health care to be paid for by the employers in their union contracts. And at that time, health insurance was not a particularly large number. And then we go all the way through the 50s and we get into the 60s. The government Congress passed the Medicare bill so that people over 65 would be their health insurance would be covered by the taxpayers.
So this was part of the war on poverty. Lyndon Johnson called it the Great Society. So the idea was we're going to go to war with destitution and poverty and cure it, get rid of it.
Right.
We've been doing that for over 50 years, and we've spent trillions of dollars, and we still have it in a relative sense.
Yes.
Right. People are they're way better off. Even poor people now are better off than they were 50 years ago, but they're still poor relative to others.
Well, I would say that the middle class might be worse off, and we'll get to that in just a second, whether or not that's true. But then, so Medicare was passed, and then Medicaid was passed, and so Medicaid was passed for lower income people. But in both cases, it meant that a third party was going to set the price and pay the claim, and it is the setting of the price and the paying of the claim that costs so much money. I'm going to give an example. When you go get your car filled up with gasoline, you pull up to the pump, you see what the price is, you take your credit or your debit card and you stick it in the pump, and then you pump your gas, and let's say it's $70 for to fill up your car, and then the credit or debit card company will take 2%. Right. Or $1.40 to move the money from your account to the gas station's account, and it's done.
From the point of view of the gasoline seller, it's done. Credit card company has given you credit. They're still depending on you to pay off that bill, right? The risk has been transferred to a credit card company. And that's what they get paid 2% to do.
Right.
Right. But from the point of view of the seller, it's over. They've got their money, never see you again, maybe.
Well, and from the standpoint of the buyer, the buyer knows how much the price is and how much they just paid.
And how much he now owes to somebody else.
Right. If you go to the doctor now, same thing. If that same person now goes to the doctor, might come in and say, "Oh, Mr. Hassel, you have a $35 copay," and then you go in and you pay the $35. You go see the doctor. The doctor then has a pretty expensive electronic medical record system that the doctor must use in order to be able to file for the claim to get the rest of what the doctor is to be paid.
Yes.
And so that's an expensive process. And then you go home, and then the electronic medical record is sent to a billing company that's a third-party billing company that interfaces with all of the different insurers that doctor might be paid by.
Yeah, I think in the industry they call them payers because some of them are insurance companies, some of them are the government. But there's a variety of different types of payers, and they're mostly invisible to the patient.
They're completely invisible. And so is the billing company, by the way.
Yeah.
And so the billing company then checks to make sure every I is dotted, every T is crossed, every code is correct.
It's accurate. Yeah.
And then that billing company then sends what the billing company believes is a correct bill to the insurer. And then the insurer then has people who do the same thing, who look at it to make sure the codes are right, the I's are dotted, T's are crossed, everything's right. And if something's wrong, it gets sent back to the billing company, which then gets sent back to the doctor to be corrected. That's an expensive process.
Right. And so after this is all over, you sometimes get a document called an explanation of benefits.
You always get it.
An EOB. You're supposed to always get it. Sometimes we get it, don't look at it. But it's got all of this in there. And if you look at it, it's a kabuki dance. They're pretending to charge a huge number. There's a huge discount. And then there's some that you've paid. And then there's something that may be around 15 or 20% of what the pretend price is. And so they do these big negotiations, and the information system is destroyed by this. And people don't know what they're paying. These discounts are illusory. You know, the street price is so different from the listed price. Nobody can manage.
Well, there is no listed price. That's the point. Is it? I mean,
before you go in, they don't tell you how much it costs.
And they won't tell you.
Yeah, but there is a fee for a certain code. You know, if you do this code, we'll pay you that fee, and then they discount it. So that's all hidden from the consumer.
Right. And that's on purpose.
Yes,
that is on purpose. And so the EOB, the explanation of benefits. So the once it is determined that the claim is accurate, then the patient receives, as you say, in the mail, a document called the EOB, or the explanation of benefits. And it might show that doctor on there was trying to charge you $250. and that the insurance company negotiated it down to $150. And then I said, but it says on there, this is not a bill. So it's informational only. So you can't do anything with it.
Right.
And then later, it goes back now to the billing company, and the billing company will then send you a bill that shows how much the insurance paid. But if you still have your annual deductible to pay, you may have to pay the difference between the $35 you've already paid and the $150 negotiated price.
Right.
But here's what's interesting. If you had gone in to see the doctor and paid by credit or debit card in full at the time of service, the price would have likely been something around $70. And then you would have been done.
Which is about 1/3 of the $250 that you started suggesting.
About half of what the so-called negotiated price is.
Yeah.
And I say this because I personally had a number of experiences with this by asking for a cash price because I didn't have insurance for that particular procedure. And what I found was that the price that I had to pay if I was paying in full was about half of the price that the physician or provider would have gotten from the insurance company, and that was then double what the so-called retail price was, double that. So let me give you an example. Years ago, I needed to have a colonoscopy, and I told the doctor, I said, I don't have insurance for this colonoscopy. Can you give me a cash price? And he said, yeah. He said if you will pay in full, the day of service, it'll be $1,200, and that'll include everything. That will include the facility, anesthesia, and me. Yeah, everything. And it's $1,200, and so I did that. And then 7 years later, when I needed my next colonoscopy, I actually did it again, same thing, and it was still $1,200, by the way. and then 7 years later, which was my last colonoscopy that I paid for myself before Medicare, it was exactly the same thing again. Dr. McGrew was my doctor. Now, that particular one, it coincided with my son coming home from college. In our family, his uncle on my wife's side died of colon cancer in his 40s.
So they start them early for that degree relative.
Well, he had some symptoms.
Right.
And I called Dr. McGrew, and I explained the symptoms. And I said, do you think my son, given his family history, do you think he ought to have a colonoscopy? He said, yes. He said, I would eliminate that the risk of cancer. Even though he's only 20, I would still want to eliminate that risk, given the symptoms that you have described.
Yes.
Well, he was on insurance. And so I said, well, we'll just run it through his insurance. So the same doctor did exactly the same procedure. When he got his EOB, it was $11,000, negotiated down to $6,000. $11,000 negotiated down to $6,000.
And the real price is $1,200.
$1,200. The real price was $1,200. Now, when my wife and that happened for me not just one time, but it happened to me 3 times at $1,200, $1,200, $1,200.
Got it. When
my wife had a bunion on her foot, I went through the same process. Now, but this is an interesting story. I originally asked the doctor because at that time, the company that I had, and in fact, you and I might have been working together, we had a medical savings account,
yes,
which had a $3,000. We had a $3,000 deductible that we had to pay.
Right.
And so my wife wanted to have her bunion taken off at the very beginning of January so that she'd have 2 winter months to recover. Because bunionectomies have a recovery time and there's a lot of pain.
Right.
So we lined up the doctor in October or November to do the procedure in an outpatient facility right at the beginning of the year. And we asked him, I said, how much will you get from the insurance company? He said, I will get $1,500. So I then knew that $1,500 would then be reduced from the $3,000. Okay, and he would file his own claim. So then I said, give me 5 places where you take off bunions, and he did. And I called those 5 places, And I said, what is your price? And they said, well, our
These are
retail,
hospitals where he would do the procedure.
not hospitals,
Or
outpatient
clinics.
outpatient facilities.
Okay.
That had all the equipment.
So this is in addition to his $1,200. You had to
His
pay
$1,500.
$1,500. You had to pay a facility. So you called 5 of them.
Called 5 of them, and their prices, because I said, what's your price? And they said, and I told them I had insurance. And they said it's $4,200 to $6,000. That was the range, and they could only tell me the retail price. I said, "Well, how much do you get? How much do you get paid by my PPO?" And I gave them the name of the PPO. They said, "Well, contractually, we cannot tell you that." All 5 of them said the same thing. Contractually, we cannot tell you that. I said, "Okay," and so then I said, "Well, give me what's your cash?"
That means they have an agreement with the payer not to pay it. The payer is the one that's not letting them get that information out.
That's correct. And this is true. This is generally how the whole industry works.
Right.
It's opaque and it's on purpose.
Right.
And so then I said, just offhandedly, I said to one of them, I said, well, what's your cash price if I paid in full? They said, well, we can't quote you that because you told us you have insurance. I said, what do you mean? They said, well, once you tell us you have insurance, we can't give you a pay in full price. I said, "Oh, okay."
Is that by contract also?
That's also by
contract. They've agreed with the payer that they'll not take that kind of business.
That's correct.
Yeah.
They can't change the price. So I said, okay. So I waited 10 days and I called all 5 of them back. And I said, I don't have insurance for this. And the way I was thinking about it myself was I still had that big part of the deductible that I was going to have to pay. So that's going to come out of pocket. I said, can you give me a cash price? And the one that said $4,200 said it would be $2,556. That's how much it would be. So I went there and I paid in full, gave them my credit card, and then I put down my insurance card. I put down a letter, the whole thing, and I said, all I want you to do is copy that insurance card front and back, take the invoice that Mark paid, stamp it paid, and send it to my insurance company so they will apply it against my deductible. And they did. And then the insurance company sent a letter back and said, we're not applying it against your deductible. You need to go through our PPO.
What does that mean?
Meaning that they said, we're not going to apply it against your deductible. You still have that deductible to pay. So I went back to the facility and I said, they won't let me do it. We need to run it through insurance. And they said, well, if it's running through insurance, it's $4,200. I said, you run it through whatever it is. So they ran it through insurance and came back, and the EOB was $3,600. Okay.
So the insurance paid the company $3,600 for something you had already paid them $2,500 for.
Right. And then they cut me a check. They then
paid you back your $2,500?
Yeah. Well, they actually signed the check over to me.
Okay. The $3,600.
Yes.
So you made $1,100.
Yes, but I wasn't intending to do it that way. I was not intending to do it that way.
I know you didn't intend it.
But here's
how
what's
perverse the whole thing is.
Here's the key thing. Here's the key thing. In each of the cases that I just described, in each of those cases, families are paying insurance companies now $1,500 to $2,000 a month to negotiate prices that are twice as high as they would be if they just simply paid in full.
Right.
So they're paying huge amounts of money. And by the way, all this tariff stuff and all this stuff, the manufacturers leaving the U.S. and going to other countries, in large part is because the healthcare costs to the manufacturers have become so great that they can move the factory and have those goods produced at a much lower price, not because the wages are necessarily that much lower, but because the health insurance costs are so much exorbitantly higher in this country. And that's much worse today than it was 20 years ago. When Barack Obama promoted Obamacare in 2010, he made a promise. He made a number of promises that turned out to be accurate. He said, if you want to keep your doctor, you can keep your doctor. That was false. If you want to keep your insurance company, you can keep your insurance.
Turned out to be inaccurate? Is that what you meant to say?
Turned out to be false.
Okay, inaccurate. Okay.
It turned out to be false. And then, but he also said this. He said, and Obamacare will reduce the cost of insurance for the average family $2,500 a year. That was the number that he said Obamacare will help everyone by reducing insurance costs. Insurance prices for the average family are now up $10,000 a year since 2010. And you see a lot of things going on at the federal level. You see DOGE, you see all of these things where they're finding waste, fraud, and abuse. But our health insurance system is inherently wasteful. Inherently, the way it is designed, it has to be wasteful, because in order to have an annual deductible, your insurance company has to know every single expense or every single time that you touch the healthcare system. It has to adjudicate that claim, right. And that is incredibly expensive.
So this is back to the point that it's no longer catastrophic expenses that insurance covers. It's every little time you get somebody to look at your nose because it itches.
Yes. When I go to my dermatologist at my age and with my fair skin,
yeah.
I have a lot of little. When my doctor goes in, he'll pick off little basal cells and little precancerous things.
And you could pay for that easily.
I could.
Yeah.
But I'm on Medicare.
Yeah.
So he won't let me pay for it.
Right.
Okay. But the amount that he gets for spending about 5 minutes on each one of those things is about $600. And so he has somebody in the office who does nothing but keep track of every single time he picks something off my skin.
So he gets $600, but then the insurer has to pay, the payer.
That's Medicare. It's just
the
Medicare
government
now.
in this case has to pay a lot more than that for all the administration.
Yes, and so there's somebody else who's handling the Medicare, that whole adjudication process. Now, and I've asked doctors, I've asked him, I said, how much would you charge me for a doctor visit if I just came in, you did that procedure, and you did it, and you were paid the day of service? He said, I don't know, probably $150. So what I'm trying to get at here is, and by the way, our providers are wonderful people who do a great service. And I'm not saying that the people in the insurance business are not fine people, but because of Roosevelt making insurance tax deductible to the employer, but not tax deductible to the individual, we have by definition, you have to have this massive system that tracks all of these expenses. And so let me give another industry, food. I will ask my friends who support big government, I said, what's more essential to human life, food or healthcare? Because these are people who say healthcare needs to be a right. I go, okay.
Yeah.
But at the end of the day, if you had to choose between having access to food or access to healthcare, or no access to food and no access to healthcare, which would you choose? And of course, food
is it. Well, your point is that food is more fundamental than healthcare.
Yes.
Housing is probably more fundamental than healthcare.
Yes. But I'm going to stick with food.
Yeah.
In the case of food, we don't have national food insurance.
Yes.
But it's more important, but we don't have national food insurance. But what we do is that we help lower income people by providing them with food stamps. Right. So we give lower income people the ability to buy food at the same prices as people who don't have food stamps pay. And so the market sets the price of food and sets the selection of food, and everything is adjudicated at the checkout.
Well, that's the simplest form of adjudication.
Yes.
Is you've got something to sell me. It costs X dollars. It's worth more than X to me, and I'm going to pay you.
Yes. And I'm either
done.
going to pay by credit or debit, and so the provider is always paid right then.
Yeah.
So,
it used to be a thing called cash.
Yeah.
That's even simpler than credit.
That's exactly right. That's exactly right.
I want to tell a brief story here. My wife spent her career in healthcare, and Nashville has a lot of healthcare companies, as our listeners may not know. A relative, through marriage, was a senior executive in one of the Fortune 50 companies here. Big national retail company. He was concerned about his healthcare costs, and he wanted to talk to Susan about what he could do about it. And so we ended this discussion. I happened to be along with them, and I said, look, Don, how would you like it if somebody got hungry, showed up at your door and said, I'm hungry, I must have food by law? You have to give them food, and then you've got a months-long process of figuring out how much that person is going to pay you or somebody else is going to pay you on their behalf. That is expensive. And he was used to people paying at checkout for their groceries.
Right. Oh, okay.
You see the point?
Yes. Yes. And so So in the case of food, and so their food stamps is the solution, and it is a good solution to help lower income people pay for food that they otherwise couldn't afford.
Right.
But the bad solution would be to say we're going to have a third party payment system to price the food, to select the food, and then when you go check out, you just check out, and we'll let you know later how much of that, what your annual deductible is, how much you have to pay, and how much the insurance company will pay. That would drive the cost of food up 300%.
Yeah.
But that's what it's done to healthcare.
Yeah.
And so Michael, as you and I, we've known each other a long time, and we don't like to talk about problems without offering a solution. So we're going to be offering a solution here. And I want to begin by saying that the solution is going to be a solution that solves what I call the rule. This does not solve the exception.
Right.
So but there is a way to look at exceptions, but you don't say that I can't solve
the rule
unless I also solve the exception the same way. Right. You can't do that. Right. That's not the way life works. And so the solution here is to have widespread to change our system, and you can do this by state. So what you can do is you can say, I want some states to try this, and I want them to volunteer. We talk about choice. We want to have some states who will choose to do this. And what they do is everybody in that state would have an HSA. The HSA, Health Savings Account. Now, in the case where their employer is paying for their insurance, now what the employer would do is fund the HSA. Okay, and so then and then lower income people would have HSAs instead of Medicaid. They would still be on a form of Medicaid, but it would be the first level of defense is your HSA, or the first payment is going to come out of the HSA in full.
Right.
And by the way, a lot of Medicaid people today, a lot of people on Medicaid, they go to emergency rooms because emergency rooms have to treat them.
Yes.
Whereas if they went to a urgent care center, which they're all over the place, if they had the ability to pay out of an HSA, it might only cost the whole system $100 for that visit rather than $2,500 to go to the ER.
ER is the most expensive form of payment.
Most expensive, and it's the one that is used frequently by people who can't afford anything else. So they go to the most expensive because they are forced to take care of them.
Right.
So you have widespread HSAs, and then providers, and this is where technology really helps. Providers of healthcare would have to sign up and register and be approved to receive payment from HSA accounts.
Let me stop you for a second just to catch up with you. I think what we're saying here is these HSA accounts would be a little fund that you have every year, and you can use it to pay for all the little stuff that doesn't need to be adjudicated.
Not even little. It would even include outpatient surgery.
But it covers certainly all the little stuff up to a certain amount. And then there's insurance for catastrophic things over that. I think the way most of these are structured, you get to keep the money if you don't spend it.
And we would do it that way, to stay in, so that as you get older, your HSA you'd be available to pay for more and more and more of your health care.
It would accumulate.
It would accumulate over time.
Mm-hmm.
And also it is yours. It is your family's. So that if you have a healthy life and then you die unexpectedly at age 65 or 70 or 75, and there's money in that HSA, your family, it's part of your estate.
Yes.
And but as that grows, it is used more and more to pay for more and more of your health care.
Right.
But the point I'm trying to make here is this is not a savings plan. That's not the goal of this. What this is the goal of this is to eliminate the third-party payment system and the adjudication for everything except the catastrophic.
Yes.
And so that way insurance in healthcare would be the same as your car insurance. It'd be the same as your homeowner's insurance. All the different insurances that we have are to provide for the unexpected.
And large.
And large. In healthcare, a doctor visit is not unexpected and should not be large. Even a colonoscopy at $1,200, or even if it's now $1,500,
normal people could afford it.
Yeah, they can afford it, especially if they have it in an HSA.
Yeah,
because then it's there, and it's to provide for their health care.
And we might say they may think they can't afford it, but if they know their alternative is to pay $2,500 through some kind of elaborate system that takes it out of their check, they'd be happy to pay $1,200.
So this system that I'm talking about, what I believe it would end up doing is the cost of health insurance would drop by at least 60%. Because it would be used, and maybe even drop 70%. I don't know what the market price would end up being, because that form of insurance would only be covering the hospitalizations and the number of times that people go to the hospital versus the number of times that they touch the healthcare system in every other way is maybe 1 in 20. So the number of claims would drop by at least 95%. But here's the other thing that would happen. Then the insurance companies would start working with hospitals on best practices. And by the way, part of this whole thing is prices need to be made. They need to be transparent.
Yes.
Even heart surgery, even cancer surgery, and hospitals will say, well, we can't tell you what it'll cost ahead of time because there might be complications. And my response to that is, yes, they are. But you can tell me what it would cost if there are no complications.
Yeah, price to the rule and not the exception.
Bingo. And so you solve for the rule, which is 90% of the problem. Yeah. Then you work on public policy by state. You work on the exception. And so and there's one other thing that our current system does that's insidious in nature, but not but something to be expected. Under Medicaid and Obamacare, states pay about a third. A state will pay about a third of the cost of Medicaid. The federal government will pay 2/3. In the case of Obamacare, the state pays 10%, and the federal government pays 90%. So what some states are doing now is they are imposing taxes on their health care providers. And then they turn around and they increase the reimbursement to those very same health care providers for Medicaid and Obamacare.
And the federal government pays for it.
And the federal government pays for
90% of it?
Yes, or pays for the increase. Yeah. Then what that does is all of that money, all that federal money that it now goes into the state, and it supports that state's economy at the expense of every other state, because it is gaming the system.
Right.
Well, more and more states are learning how to game the system.
There's two points or observations I'd like to make here. One is that the market is a giant information system. Prices tell you what something is worth, right? And when you don't have prices, you get all of these distortions because people don't have the information to make wise choices. So ideologically, somebody that's in favor of the market is in favor of transparency so that we can manage these kinds of things, right? The other observation I would make is that what we're discussing is the idea behind block grants to the states, where the government just says, we're out of this business, all of this hocus pocus.
The federal government does.
The federal government says, we're going to stop this. We're just going to give what we're spending now to the states. You figure out a better way.
Right. And that's for Medicaid. That'd be for Medicaid and Obamacare. But even then, people who are on Medicaid, they should have an HSA as part of their Medicaid, because we need for people who are on Medicaid to be able to see the price, make decisions. And people who are on Medicaid, they might have low incomes, but they're very, very price conscious. And if they know
they're not stupid.
That's right. And if they know it's their money, if they go to the emergency room and the emergency room go ding them for $1,000, but they can go to an urgent care center that's going to charge them $80, they're going to go to the urgent care center, and which would also mean that you would have more healthcare facilities that serve those needs more closer to those neighborhoods. And so
I think you could say that our current system treats these people as if they are incompetent.
That's right.
And incapable of managing this and doing what's in their own interest.
Yes, and what is driving the healthcare system today is, by the way, and pharmaceutical companies, they provide wonderful products. But the way that our system is set up now is if pharmaceutical companies want to make more and more profits, then they have ways of doing that now within our current system. Because once again, when you go to buy pharmaceuticals, you don't know what the price is, and the price does not come out of it's paid for by an insurance plan, and then if the cost of pharmaceuticals goes up, the insurance plans just raise their premiums, and so that then becomes part of why smaller businesses are getting crushed by the insurance system that we have, and manufacturing companies are also getting killed, and that's why they moved manufacturing out of the country. So if we're going to move manufacturing back to the U.S., which I think is a very good thing, and we want middle income Americans to have a good life and be able to save for their own retirements and have something to leave for their children, then we need to fix the healthcare system, which has now gotten to be. Let's pull up a chart here that just shows this chart right here shows the cost of medical care compared to the overall CPI since 2001. So as you can see,
Consumer Price Index.
Consumer Price Index. So as you can see, throughout that entire time, the cost of medical care has gone up faster than the overall CPI. And we talk about a word called unsustainable. If this continues, go to the next chart, please. This shows Medicare enrollment as a percentage of the population. This is the baby boomers. That's what we are
now.
They've been retired, but they haven't really started to kick in on healthcare costs, because healthcare costs really kick in when you pass 80. The oldest baby boomers are now just hitting 80. The youngest are hitting 65.
Just starting to retire.
So this chart is going to even be worse. Go to the next one, please. This shows the Medicare spending from 1970 to 2023. Now, as you can see, between 2000 and 2011, the amount jumped dramatically. And that's where Congress changed the legislation to cover more things. But it's also where providers, quite frankly, figured out how they could game the system themselves. But then the costs continue to rise and continue to rise. And this is, once again, we cannot continue to pay for a system the same way we have. Go to the next slide, please. Look at this one. And this one is very interesting, because notice that the very end of it, 2025 to 2030, those are the 5 years that we are about to hit. This is the historic and projected Medicare income and expenditures over time. This is where I said the baby boomers are about to start hitting 80. Look at what happens in the next 5 years if we don't correct this system. We've got to do this, and the way to do it is to recognize that the biggest cost in our healthcare system is not what the providers get, it's the payment system itself. So please go to the next chart.
Let me say a word about baby boomers. This was people born just after World War II, when there's a lot of pent-up demand to start families and houses. There was a big boom, and a lot of people, an unusual number of people born in that period.
Yes.
So it's like the mouse going through the snake.
Yes.
Right. It's the bulge, and now they're getting to an age where they're expensive, they're old, and their healthcare costs go way up.
Right.
And it's going to be paid by the people coming behind.
Right. And that's where, thank you. And that's where people who are younger and healthier, because the government mandates that people will have some form of insurance, younger people are paying a disproportionate amount of their income to pay for insurance that covers the cost of older people. But it really isn't covering the cost of the older people. It's covering the system. It's covering the third-party payment system that allows for older people to be paid. So what I'm saying is that the system itself is poorly designed. And, Elon Musk and his Doge team are discovering all kinds. They're actually discovering a lot of fraud. And in our healthcare system, the way it is designed is inherently wasteful. So Doge may not find waste in Medicare and Medicaid in the payment system. May not find it because it's the way it's designed. So we need to recognize that it is the design itself. And we need to say, how do we handle food? We handle food for low-income people with food stamps. How do we handle car insurance? We don't have an annual deductible for operating your car. We only cover the catastrophic. How do we cover homeowners? We don't have an annual deductible for every cost in your home. It's only if you have
a fire or
a
explosion.
fire or something, a tree falls on your roof or something like that. Is there another? Did we have? And so this is the total Medicaid. So I just want you to see.
So Medicare is for older people.
Yes.
It's for retirees.
Thank you.
Medicaid is for poor people.
Yes. Yeah. But more and more middle income people are now being forced onto Medicaid through Obamacare because you can get it subsidized, and somebody
So you're talking about pre-retirement people.
Oh yes,
yeah.
I'm saying people.
All retired people are forced onto Medicare.
That's Medicare.
Medicare.
I'm talking about Medicaid.
Okay.
Yeah. Medicaid. If you are making, I don't know what the number is, but I know it's at $80,000. If you're a family of four, you qualify for Obamacare, and so you can buy insurance under Obamacare much cheaper. But then the cost to the taxpayers for the third-party payment system that adjudicates Obamacare is explosive.
Right.
And so that's where this spending. This isn't the number of people. This is how much we spend. And this is the adjudication cost, not all of it. Some of this, a good bit of it, probably 50%, 40% goes to the providers, but the rest of it is adjudication. And so we're spending money not for people who need their health care.
Not for the health care itself, for the means of paying for it.
Yes, exactly.
Let me say a word about embeddedness. One of the real evils here is invisibility. We talk about transparency, but all of this is built into prices that we seem to feel like we're out of control and can't do, right? It's embedded in our tax system. It's embedded in our price level at the end. We were talking about energy before we started this. Energy is about 1/3, I think, of these costs. It's about $5,000 a year or something. We looked this up.
Yes.
And you said for the average person, it's what, $1,250 a year? For healthcare?
Healthcare?
So, yeah, almost 3 times as much as energy. And
15,000.
15,000 versus 5,000. So it's about a factor of 3.
Yeah.
And there's a lot of effort now to deregulate energy, because everything includes energy. I've got a coffee cup here, right? Well, it costs money to ship the cup. It costs money to roast the beans. That's all energy, but it ends up being embedded in the $5 I might have paid for this.
Right.
And so we're paying for energy. We just don't see it.
That's correct.
Okay, and this is the evil of this invisible system, is that it embeds costs, so we really don't know what we're paying for.
Well, and with healthcare, yes, and so healthcare for the same coffee. If you go into Starbucks, the cost of the energy that might be attributed to buying a cup of coffee for $5 might be 50 cents. The cost of healthcare is going to be maybe $1.
Oh, 3 times as much.
Yeah, the only expense for a business now, the only expense that's bigger than their healthcare costs is the salaries. But the salaries are lowered. They have to the businesses
by the amount they were spending for healthcare.
Yeah, and so the way a business looks at the cost of an employee is they add the salaries, all of the benefits, including health care, Social Security costs that the company has to pay, Medicare costs, workman's comp, unemployment benefits. So all of these different things go into the cost of labor. And so if people want to have a higher standard of living, then we need to look at some of these. And the one I want to look at is healthcare, because healthcare is now it's now the biggest. And it's the one that is, and it can be resolved by going to individual states and then doing some tests, experimenting with this, and the thing that's so interesting about this is not saying, well, this may not work. Well, it works in homeowners, it works in car insurance, it works with food stamps. In every other way, we know how to help lower income people and still keep a market system in place for the society as a whole, which makes us competitive and holds down prices. Insurance doesn't do that.
Right.
Health insurance goes up on its own, and there's nothing that anybody can do about it because the system is designed is what it is because the government says it will be this way.
Right. It encourages resignation.
Yes.
It's beyond my control. I just have to live with it.
Yeah.
Let me finish a point about embeddedness. The reason I brought up energy it's an abstract point. Who cares, how much energy was to roast the beans? I just paid $5 for this coffee. It was worth that to me, and I'm done.
Right.
I adjudicated at the point.
Right.
But what I'm trying to say is if you're able to lower energy prices, which is what's going on now, their efforts to deregulate, the purpose is to lower energy prices. It cuts the cost of everything.
Yes.
Of the cups, of the coffee. You lower energy prices and all the prices go down.
Right.
Same with healthcare. If you can get a hold of this and these embedded prices that are invisible to us, the prices of homes, of services, of everything else goes down. Everything
goes down. In fact, if we can address the inefficiencies that are inherent in our healthcare system, it can have a greater positive impact on society than any other single system. So, Mike, I thank you for being with me today.
This has been fun. It's there's some arcane kind of stuff in here, but I think it's really important to grapple with this because if we can improve this, all of our lives can really be substantially improved.
And let me say one other thing. I'd like for people who have comments on this particular podcast to go to our website, From Our Generation, and I'm hoping that we have a place there where they can comment. And there's on that website they can place comments, they can place questions. I'd like to get feedback.
That'd be great.
Because this is as we talk about things that are not sustainable. Our healthcare system is simply not sustainable. And because the baby boomers are going to be hitting the age where they start to really access the system, we need to address this very, very quickly.
I'd like to plant a seed for a future discussion, and that is we've talked about heading off a cliff in our prior ones. We've talked about unsustainable. I want to talk about what that means.
Yeah.
What does it mean if a country collapses? The people are there the next day. The buildings are there the next day. It happened in Russia. The Soviet Union went away. But what changed?
Well,
right, and so we're headed for that kind of event. There's been 5 republics, I think, in France since the big revolution. They keep reforming their government, but the wealth that's lost, the practices and patterns that built the civilization are changed.
Yes.
And that's what I want to probe into at a future.
Yeah, that'd be great. That'd be great. Look forward to it.
All right.
Thanks a lot.